comments? Without further ado, research to practice, advanced technologies in radiation oncology impact on our day-to-day practice with Arthur Blackstock, Jr., MD. And let me just say that Dr. Blackstock, MD, is a professor and chairman of the Department of Radiation Oncology at Wake Forest University School of Medicine in Winston-Salem, North Carolina. He is a national and international expert in radiotherapeutic management of gastrointestinal cancers. After 1 year on faculty at UNC, Dr. Blackstock accepted an assistant professor position at the WFU School of Medicine in 1996. He has been the principal investigator or co-PI of numerous clinical trials in lung cancer and malignancies of the gastrointestinal tract. He serves on the editorial boards of numerous prestigious journals and currently serves on the NCI Board of Scientific Council Intramural Program. Dr. Blackstock serves as co-chair of the NCI Thoracic Malignancies Steering Committee and remains active serving on the NCI Designated Pancreatic Task Force. Dr. Blackstock is also director of the clinical research program at the NCI Designated Comprehensive Cancer Center at Wake Forest University. Dr. Blackstock, welcome. It is so good to have you here today.
No, and thank you for the kind introduction. I did want to say, you mentioned it already, I did spend about a decade at UNC. I did my residency in radiation oncology. I stayed on as a fellow under the direction of Joel Tepper, but certainly worked a lot with Shelley Earp and those folks at Lineberger, enjoyed that 3-year fellowship, stayed on for a year. And then my wife decided we were better off in Winston-Salem where we met at Wake Forest. So, but I've always had a fondness for UNC and Chapel Hill. And again, it's my pleasure to give this presentation. I do want to give a little bit of a disclaimer though, because this is a little bit of a dense physics talk. And if there's any learners out there, potential students, medical students, radiation oncology is not this dense in physics. It's actually a very diverse profession. I'm always encouraging people to look at it and consider it as a profession. But when you hear this presentation, if you think this is what I do every day, it's not what I do every day. I see patients that take care of people with cancer. But having said that, this is a bit of a physics dense conversation just because of the topics I'm covering. Next slide.
Good to know. And what is there something you might tell us about your personal life outside of your professional bio there?
Well, the biggest news in the most recent is we went down to St. John's with a young man, and he proposed to my daughter. He's from Czech Republic, and so my daughter's now engaged. He plays hockey for the Carolina Thunderbirds, and we're looking at a wedding probably next spring or early next summer. And for now, I like the young man. Hopefully he'll stay clear, and I'll like him when she makes it.
Well, congratulations. That is really great news. All the best to you. I mentioned poll everywhere. We're going to use that. Proton therapy, also called proton beam therapy, is a type of radiation therapy that uses protons rather than photon X-rays to treat cancer. So take a look at this. This is actually just a screenshot, but you'll see the real poll everywhere pop up in just a moment, and go ahead and put in your best answer for that. While you're doing that, I'm going to say that this activity has been planned and implemented under the sole supervision of the course director, William A. Wood, MD, MPH, in association with the UNC Office of Continuing Professional Development. The course director and CPD staff have no relevant relationships with ineligible companies as defined by the ACCME. The University of North Carolina, Chapel Hill is accredited with distinction as a provider of nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. The potential conflict of interest occurs when an individual has an opportunity to affect educational content about healthcare products or services of a commercial interest with which he or she has financial relationships. The speakers and planners of this learning activity have not disclosed any relevant financial relationships with any commercial interests pertaining to this activity. The presenter has no relevant financial relationships with ineligible companies as defined by the ACCME. Thank you for letting me share that. And here, you know what? This poll everywhere isn't quite doing what we want it to, which is and I think I might know why. So bear with me for just a moment. Let's see if we can fix that. Dr. Blackstock, I apologize.
Not a problem.
We thought we had this all working properly. Of course, you test it several times and it works just fine. And now it seems to be acting up just a little bit. I am looking, I'm able to see the poll separately from here, and I'm seeing that there's folks are running strongly on the true or A. How are they doing?
Well, true is the right answer. We are now moving toward a field of proton therapy that it won't ever replace photon therapy, but the use of protons in cancer is starting to expand as we start to do more clinical trials. As I get toward the end of my presentation, you'll see at least a couple of trials where we tested protons versus photons, and it'll just give you some sense of what we're learning from those studies. Again, I'm at Wake Forest. The introduction again was very kind. I have no disclosures. Few years ago, when I started doing a lot of work with the NCI and the ASCO board, they all encouraged all of us to sort of make sure we stay clear of those sorts of things. So when you get caught up in the Sunshine Act, that the New York Times comes to visit you because you've been making decisions and you're conflicted. So I've had no disclosures. Next slide. So proton therapy, just like photon therapy, there's really three paths that we use this treatment for. Just in general, again, this applies to photons. It applies to, I guess, any therapy that's anti-cancer that comes out of my department. But there's definitive radiation, proton radiation, which is the intent is curative. And probably for radiation more than any other modality, maybe not surgical oncology, our focus is on durable local control. We're not a systemic therapy. We are a targeted, what I mean by targeted therapy, we aim the beam and we treat an area that we think is at risk, and any other areas around that area, lymph nodes that might be at risk. But that's our function, is a local treatment for patients with cancer. Adjuvantly, we often are asked to treat patients who've had surgical resections, who've had chemotherapy or other therapies to make sure we decrease the probability of recurrence after surgery. Again, it can be after chemotherapy as well, but that's an adjuvant role, and that's still all in a curative way. And then obviously there's patients who come in with disease that they're no longer curative disease, but we certainly spend a fair bit of time in our clinic treating folks with palliative radiation, whether it be protons or photons, to improve symptoms if you're having pain or you're having some obstruction from a tumor. That's our third role in oncology. Next slide. So, I'm going to walk through this a little bit. It's a bit of history, and I hope it's a little bit fun for some folks. Right now there's no proton units in the state of North Carolina. UNC and Duke have both talked about proceeding with a proton unit. I don't know where those talks are, but that it hasn't materialized into a proton center yet. But it does, provide an alternative treatment for patients who maybe aren't best treated with photon therapy. Proton therapy is a particle therapy, just like carbon ions, and I'll explain it a little bit more later. But proton is a positively charged particle. It has different effects in terms of how it treats tumors in biology and physics, as opposed to a photon-based therapy, which actually is initiated from an electron with a negative charge, and then that provides photons, and then that's a different strategy with photons. There's different modalities I'm going to speak about in this presentation. 3D conformal, you'll hear a lot about 3D conformal, but then intensity modulated radiation therapy, IMRT. I have to confess, we are a horrible discipline about acronyms, and it doesn't help people understand what we do. And maybe we do it on, purposefully. That way you don't quite understand what we do. But there's 3D therapy. Intentionally modulated therapy was new to me when I finished up my residency and fellowship at UNC. And now in the last 5 to 10 years, there's been the development of stereotactic radiosurgery. That primarily was for brain tumors, but that technology then moved over to other parts of the body. And we refer to that as SBRT, or Stereotactic Body Radiation Therapy. Again, a lot of acronyms, but it's just different ways different ways to provide radiation treatments. And then I always like to make sure I don't forget brachytherapy. A lot of folks will talk about my dad had a prostate implant, or my mom had a GYN procedure done. And there's multiple ways you can do brachytherapy. And brachytherapy is the insertion of radioactive material, if you will. For gentlemen who need a prostate implant, we actually place the radioactive seeds in the operating room into the prostate, probably 20, 30, 40 seeds, depending on the volume you have to cover. And you can do that with a high dose rate radiation, or you can do that with low dose rate radiation. And that really depends on the seed and the strength of the seed that you're implanting. And then finally, I'd like to mention intraoperative radiotherapy. I do that because I'm a big UNC fan, and UNC, Duke, and Wake Forest. Oh, I know, way before I became chair here at Wake Forest, decided that we really only needed one intraoperative unit. There wasn't enough volume in the state to require 3. So we've actually left that expertise to UNC and Joel Tepper and his team. So when I see a patient 3 or 4 times a year, and Duke sees a patient, I think they do the same thing. We actually send them to the UNC folks because they have the expertise in intraoperative. Not to mention they have a LINAC in the operating room, which is a very expensive endeavor. And you don't really want to spend that sort of money when you're treating 4 or 5 patients a year. Next slide, please. So again, UNC and Duke came out with the first proposal for proton therapy. That was probably 5 years ago. Admittedly, Duke sort of wanted to go, I speak a little bit candid, but they wanted to go their own way on a lot of this stuff, and that's fine. Duke can be Duke. My wife was a Dookie. But, we talked to UNC and Larry Marks for a long time about partnering with their proton facility. And I'll just be quite honest with you, reimbursements for protons has really dropped in the last 5, 6 years. And I think that really affects how much you are willing to invest in a proton facility. And I'm going to get into some numbers with you. I think it just gives you some perspective in terms of why does North Carolina not have a proton facility when some states have 2 or 3? And MD Anderson started the program in 2006, 2007. Why are we talking about it in 2022? But Levine, Wake Forest, we're partners, and our cancer centers are going to be joint cancer centers. We're going through that process right now. But we are developing right now the Levine Cancer Center, Wake Forest Comprehensive Center proton facility. Doesn't have a name quite yet, but we hope we'll get a big donor in, and if a big donor comes in, we can name it after that donor. It's a 2-vault facility. That means you could treat 2 patients at once in the 2-vault facility. And I got to give credit for Jim Urbanek. I should have done it at the beginning. I apologize. Some of these slides I'm presenting to you actually were provided by Jim Urbanek. He's the proton therapy director at Scripps in San Diego. So just want to make sure I give Jim full credit. He's a former resident of mine at Wake Forest. Very proud of him. He's done so well. But what we're proposing with the Levine group is a 2-vault facility. Actually, Scripps has a 5-vault facility, and they may not use all those 5 volts. They certainly have volume that one day they may get up to 5 volts. We projected in North Carolina, particularly with UNC and Duke, thinking about starting their own centers. We wouldn't think about a vault more than 2 volts because we never need more than 2 volts. The company we're using is Mevion, just as information. We've broken ground on it. It was in March of this year. So it takes 2 years to actually develop a proton or to put a proton facility together. It's probably a 2 or 3 story deep hole in the ground. You have to do that because of the size of the cyclotron, which I'll talk about in a little while. We did agree to put it in Midtown Charlotte just because we felt that was a little more easy for patients to get in and out of, and not halfway between Winston-Salem and Charlotte. We felt that didn't make sense. And then there's some details about the room. I did like to mention the last bullet. There was a dedicated pediatric nursing care unit, if you will. And to me, and this is important, if I could send a message, probably the one true indication for proton therapy is pediatrics and children and young adults. When we have a child who we think needs radiation that's seen at Wake Forest, we currently use St. Jude's. They have a proton center. I keep mentioning this. I had a former resident who's actually attending there. And to me, they have the expertise that when I send a child to St. Jude's, I know they're going to get best care. But that's where we send our current pediatric populations. I would assume that the Levine Cancer Children's Hospital, our Children's Hospital, and anybody in the state, well, as soon as this facility becomes available, we'll use it as a resource, because if there's one place where I think proton therapy is where you need to be is with pediatrics and kids. And as I talk about some of the physics of this, I'll make sense why that's important. The other piece to this, which is just as an aside, it's going to be fun. When MD Anderson provided one of the first facilities in 2006, 2007, it was $220 million to develop a proton center. And they did it, multiple ways. But the cost has now come down. Duke's proposal, which I've seen, is $88 million. I think UNC's facility is around $48 million. And the center we're proposing right now is $69 million. And you can imagine that is a hefty investment for a cancer center or even a health system to invest in. And I understand the pause that UNC and Duke have put on their centers, because as reimbursement has gone down, the ability to really pay for that unit has become harder. I like the fact that I'm bragging a little bit that, we went out front with UNC and Duke because we just financially couldn't do it at Wake Forest. But we should have the first, facility with protons online in the state. It'll be 2024 and that system's online. And I'm real happy that we should have a proton center in the state of North Carolina. We don't need 3. Sorry, UNC. Sorry, Duke. But you don't need 3 in a state this size. But you probably need 1, and that'll keep it busy. And just to give you a sense, and this is probably not appropriate, but I like people to understand why the numbers are so important. There was a time when you could treat a patient with a proton center and you could bill $120,000 for the same procedure that you could do on a photon machine for half that amount of money. So unfortunately, there was some incentive financially for the early adopters to get into the game, because there was some financial incentive to do it. I sort of like where it's landed. It's getting less expensive, as I've just mentioned. UNC was in the $48 million range, still a ton of money, but I think that's not a reasonable amount of money to spend, given there's some value in protons. And we're not incentivized by dollars. Lovely, UNC is state school, doesn't have to worry about it. With Levine partnering with us and the Levine family maybe helping out, we won't have to have any financial incentive. And I won't comment on how Duke's doing theirs, but it's a good thing we're going to have protons in the state of North Carolina very soon. Next slide. Yeah, I'll pitch in a bit. This is the facility in Midtown Charlotte. It's a dedicated facility for protons. There may be a gamma knife unit in there as well. Beautiful facility. And again, it's interesting when we first broke ground, you don't realize how deep a hole you have to put a cyclotron in, but it's about 3 stories deep in terms of where the bottom of that building is. Next slide. And again, just to show you what it looks like, that's the Mevion, and the way the table's configured and the way the beams are configured. It's just to let you see when a patient enters a room, this is what they see. And it's not undifferent than a LINAC that provides photon therapy. They're very similar. It's just the proton comes out as opposed to a photon. And again, we're going to get into some physics in a second here that describes why we think there may be advantage to that. But you can see how the patient will lay on that black table, and then Mevion unit would then rotate around that the head would rotate around that patient. You move the table in and out and up and down. That way you get the angles you want to get. Next slide. So here's some physics, and I apologize, but I don't know any other way to describe this except to do a little bit of physics. 3D, which is what I was trained on when I was at UNC in the 90s, was absolutely excellent therapy. It certainly cured patients. It still cures patients, and some folks don't really need anything more than 3D. But as you can see, and I'm trying to describe this a little bit, if you look at the tumor in the esophagus, this is an esophageal case. The red cloud or pink cloud is really where you want dose to be, because that's where your cancer is. Unfortunately, to deliver dose to that esophageal tumor, you have to go through some normal structures. And I hope you can see this, but you can see the cloud that's in the lungs, the cloud here anteriorly. Even more relevant, you see some of the dose that's in the heart. And we understand radiation long-term can do significant cardiac damage if it's not done appropriately. So you like to minimize this. And unfortunately with 3D, you can work to minimize it as best you can, but it's not as effective as you'll see with other strategies and techniques. And the other thing I'd like to describe is when we actually look at these, when I was back at UNC with 3D, we actually had to determine structures and areas that we wanted to not treat, dose constraints, if you will, with our eyeballs. We had to basically just look at the imaging and look at the scan and say, is that too much cardiac dose? Is it not enough? Is it too much volume of cardiac dose? And while we had parameters around what that should be and what it shouldn't be, it really was not the most sophisticated way of sort of eyeballing and trying to figure if you're going to be okay or not okay for long-term effects. And in radiation oncology, long-term effects is always concerned with no matter what radiation, photons, protons, regardless. You want to make sure late effects don't come down the road on you and do harm to a patient. Next slide. So then we moved up forward. So this is as I was leaving UNC, we started looking at image modulated radiation therapy, which, this was an improvement As you can see, again, here's an esophageal cancer. Pink volume is where you want to see high dose, which is what we're doing. We're delivering tumor dose to the esophageal cancer. But if you look at the lung volumes, they look to me a lot better actually than the 3D plan. You see less dose to the lungs. You see that the dose in the heart's reduced. It's pulled back a fair bit. You really can't dose much of the esophagus without dosing some of the heart. But you do see that this is a much improved plan in terms of worried about late effects and late toxicity with delivering radiation to a patient with esophageal cancer. Next slide, please. So here's protons. And I'm going to look at the picture to this side over here to the right, to my right. So this again is esophageal cancer. You can see that the nice pink dose cloud is dosing the esophagus just like you want. That's where you want the dose. But if you look at the dose to the lungs, it's much improved. It's much improved from photons. It's much improved from IMRT. And then there's at least a little more forgiveness with the cardiac dose. And one of the things that came along with technology is that we now can actually program in the computer. I couldn't do this at UNC when I was there in the 90s, but now you can actually tell the computer that's doing the planning to do dose constraints. So you can actually tell your planning system, I want 10% of the heart to see less than 20% of the dose. And it'll design the beams for you. It'll tell you where dose is coming in, where it's not going in. And sometimes, no matter what you tell the computer, it can't make it work. It'll tell you can't get the dose to the esophagus with the constraints you put in, and you have to change your constraints. And there are now published data. I'm not saying that the most reliable data around late effects for almost everything we do now. So we're not eyeballing, we're not just guessing. We're actually looking at dose constraints from big studies where you saw toxicity if you went above a certain dose to the heart or the lungs, or you didn't if you went below a certain dose to the heart and the lungs. And then we try to make sure we stay within those constraints. Those parameters have been very helpful moving forward because now we sort of feel, at least I feel better about what I'm doing with normal tissue injury. And you keep hearing me talk about normal tissue injury. And we can cure an esophageal cancer, but we can't cure esophageal cancer if we're going to cause late effects that compromise the patient's ability to survive. And I think you can agree that that lung dose is much better than it was for 3D. And you're less likely to get into some radiation pulmonary toxicity with a field like this than with a field with 3D. In some cases, it matters. Again, in esophageal cancer, I think it matters. There's some studies that say it matters, that proton may be improvements certainly over 3D, a little bit of improvement over intensity modulated radiotherapy, but not all diseases need protons. And that's going to be I want to make that point. The prostate guys have all wanted to have protons because some of the early literature with protons talked about how the dose constraints were much better. You had less late effects with protons versus just photons or IMRT or intensity modulated radiotherapy. And after the studies were done, I mean, that was the assumption, right? That was the assumption that protons would be better for prostate. It turns out that several studies and randomized trials have shown that you really don't get a better outcome and the toxicity is really not different. And I think if there's one place that if you really want to convince me that protons is where I need to go, it's with toxicity issues, late effects, as I keep saying. And that's why I'm going to talk about pediatrics right now when I get to this next slide with Bragg Peak. Next slide, please. Well, that's the cyclotron. Cyclotron, that's the thing that sits at the bottom of the 2-story building, 3-story building under the earth that produces the particle therapy. And so the cyclotron generates particles that then propels those into an alternating electric field that's in a constant magnetic field. Again, that's physics talk. But what it basically is talking about is just getting the proton moving as fast as you can get it moving. And that way, when it hits the source to provide proton therapy, it's at a high energy dose, but you want high energies for protons. But you need a cyclotron unit to do that and generate protons at that sort of speed. But that's what it looks like. The first 2 proton facilities in the U.S. were actually at Mass General Harvard and Loma Linda. There's more now. There's actually 150 units in the States right now. But really the two places, in my opinion, that really helped us in the 70s and 80s understand proton therapy was MGH and the folks at Loma Linda. Unfortunately, as I mentioned, again, the number of proton facilities is reducing. The folks who tried, and I'm going to speak candidly, the folks who got in when the money was good, I found out the money's not as good, and you can still make a profitable center, but not at the rate some of these folks were anticipating. So if you look around the country the last 3 or 4 years anyway, you've seen a reduction in proton facilities. They've just started to shut down because they can't financially make it work. In my opinion, I have a strong opinion about it. if you hadn't thought about it that far ahead because you were trying to make profit, you probably shouldn't have been into business to start with. That's just William's opinion. Next slide. Okay, so proton therapy components. I think the next slide. So that's actually where the wave, where the protons are sent through, and the microwave and all that stuff speeds up those protons. It's just just gives you a sense of the size of the cyclotron. You saw where the protons are generated, but then those protons have to come out of the cyclotron, and it needs that sort of space just to get up to speed so that you can use them for therapeutic, purposes. But it's a pretty expensive endeavor. It's pretty significant in terms of space and time. I like to tell folks that proton units usually treat during the day, but as soon as you turn a proton unit off at 9 o'clock at night, if you're treating that late, the engineers and the physicists start working, and they work through the night. Maintenance of a proton facility is pretty significant. And so it's just funny. I've not been at, I don't work at one yet, but they talk about almost 2 different shifts. The physicians and patients physicians are there treating patients during the daytime, and then an army of physicists and engineers show up at nighttime to make sure it's ready to go the next day. A lot of maintenance on a proton facility, if as you can imagine. Next slide. So here's the physics, and I hope I do this in a way that makes some sense. If not, I've done a bad job. But when the protons hit, you have to get a scatter device that allows your beam to have more of a width in terms of what areas it can treat. For example, right here is basically a proton beam that has had no beam scatter. And you can see that the maximum dose, which is what you want to do when you treat a tumor, is here, but the volume that you can treat at that level is not what you want it to be for not every patient. There may be some optic things and some very, very small lesions, but in general, you don't have much you can treat with a proton beam that's that narrow. You use the first scatter foil, that's the term I use, and you can see that you've now widened that Bragg peak. That's what we call this area where we want to deliver dose. The Bragg peak has gotten a little wider, and now you actually can treat something that can fit into this beam. And if that's not adequate, you put another second scatter, and that actually gives you more of a width in terms of or volume that you can treat. So the beauty of protons, and this is really, again, if I can make a point of this, what's the big deal? Because protons are really no more effective than photons. It doesn't kill more tumor cells. But this is where the advantages are, folks. Maybe I'll use this center one. Protons, when they enter the patient, it's almost 0 dose, or at least close to 0 dose. Photons don't work that way. Photons go up gradually, and photons drop off there gradually. Protons come in, and you get the Bragg peak, which can be as sharp as that. And then as soon as you hopefully have treated tumor volume, the dose drops dramatically. And where that is important for pediatrics, again, this is, if I could make a couple of points. If you're treating a spinal cord or a tumor in front of a spinal cord on the child, what you want to do is treat that tumor, but you don't want to treat the spinal cord. Because if you do, you can do damage to the spinal cord, and you can have growth deformities in pediatric kids. And you just don't want to use radiation in a kid unless it's necessary. And if you do, tissue sparing is so critical in kids. Because even though you cure patients with radiation that are pediatric patients, but you can leave those folks with some abnormalities that just make it difficult for them to move on. So that's why we all have fallen in love with protons, is because you can have such a low dose going in, such a low dose going out, and you can spare everything in front and in back. Same example here, but you can see, even though this is a wider field or a wider volume, you still have that advantage of going up quickly, treating the area you need to treat, and the dose drops off quickly. Again, photons doesn't look like that. Photons looks more like this. So that's the advantage of protons. Hope that made a little bit of sense. Next slide. Another example of that, and again, that's just the beam scatter I was just describing to you. This is, again, the Bragg peak is what we talk about. This is the Bragg peak, but you want to put a beam scatter in just so you can actually get more of a field that's a little wider, if you need a wider field. Or maybe you don't put as much beam scatter in because you don't want a wider field. And that gives you the advantages, in my opinion, for a lot of things, particularly for pediatric patients, where you really do want to focus on sparing normal tissue. Late effects in kids can be not a good thing. I'm positive about my profession, but I think something we learned in the 50s and 60s was you really can do harm to a child, even though you may have helped cure that patient, but they can live with some some difficulties later in life because of the radiation that was delivered to normal tissues. So it's a place that I hope that I'm a little bit of a a deviation or sidebar, that's where I hope the proton unit in Charlotte really gets used. I hope if we're the only place in the state, not even the state, but in the Southeast, Emory has one. I think UVA is getting one, but there's a catchment area for us to really be the proton center for folks in North Carolina, Tennessee, et cetera. And that's why I would like to focus the emphasis is making sure when people see a child with cancer, they don't forget the protons can be really helpful to them. And our kids going to Charlotte will be a lot easier than those kids going to St. Jude's. Next slide, please. So this is basically trying to show you when you have inhomogeneity, like an air pocket, sometimes you have to make sure when you're bringing the proton beam in, if you will, if the dose is coming in, this can affect how you cover the target volume. So air is a problem for us in all radiation, not just protons, but photons. And you have to count for that. Otherwise, you're going to have maybe not the volume you want, or at least a volume that's optimal for that patient. Next slide, please. Now you've got modulation, right? Now you've got some inhomogeneity because of the air pocket, but now you made up the inhomogeneity because you've added a scatter beam just to make sure you're covering that target volume like you want to. You're not compromising the air pocket. You made amendments for the air pocket. Now you've got a much better feel, a much better opportunity to deliver dose that's going to be effective and appropriate in the right place for this patient. Next slide, please. That might be a repeat. Next slide, please. Next slide, please. Sorry. Well, that last piece maybe helps a little bit because that does show you what we do when we say scatter beam. But the scatter beam has to go through a field shaping. Usually this is lead or something very thick. So when you shape your beam, it actually requires you to put in a device that's really dense, and that way you can actually shape. So I guess when I say that you don't really scatter beam with this, but you shape the beam with this, and then later on you get the scatter beam. Thank you. Next slide, please. And now you can see what that looks like. You got a little bit better shape. I love this dosimetric coverage on this target volume. It's just a cartoon, but look at how that works in terms of how the dose falls off at the back. And if you look at things, this would be the dose to the tumor. But you can see when you get out here, you don't have hardly any dose to the tumor, not so much on the front end. But in this example, you can see that the dose falls off, and all the good stuff out here that you don't want to treat is actually spared because you can have protons will actually do that for you as opposed to photons. Next slide, please. I'm trying to impress you with the level of complexity. You know, it's almost like, I don't know, it's even more complex than flying a 747. This is what the therapists have to deal with every day when they're treating patients. We're very careful. We try to do things within millimeters. And so accuracy is all we're about. Most of our imaging now is on the machine. So when you are on a table getting radiation, whether it's photons or protons, if it's a really complex setup, you get a CT scan every day before you get treated. Now, it's a low dose CT because we understand that there's some risk with that. But if you really want to be precise, and protons really need you to be precise, bad things can happen if you're not precise. You can deliver a dose where you don't want to deliver it. And so we actually go out of the way to bring in additional imaging. We have CT imaging on every machine. All protons have CT imaging. There are now people developing MR imaging for some machines where MR might be better than CT to delineate tumor volumes. But as you can imagine, that's a complex setup, and it really requires a lot of input. In my department, we have 11 physicists, about 6-8 dosimetrists, and those folks are actually there to help us with the physics because I don't know the physics like I used to know the physics. But they are there to help me with the physics, and I'm sure with this proton facility, it'll be an army of physicists and an army of engineers help us make sure we get things done in a safe way. Just as an aside, again, this is heavily regulated by the state. They come in to visit you. They come in unannounced to visit you. Each machine, I think this is interesting, has a record and verify. So if a state person comes in and says, William, I want to look at the last 5 treatments on this machine and what you said you were going to deliver with your prescription, and then we look at the machine tells you what was done. So you can't not, the truth is the truth. So if you said I was going to deliver, a certain dose and the machine says we only deliver another dose, that means an error was made, and the state will talk to you about that. But I love the record and verify because it does let you confirm, and we do it on our own. We actually go back and look on our own just for QA to make sure what we prescribed is what the machine is delivering. And that's why you need an army of physicists for this process, because that work takes place after hours and sometimes at nights. But this is an example of how complex this could be, but we make it work. Next slide. Another example this is an example of a lung cancer tumor. They had prior radiation to the chest, stereotactic body radiotherapy. This patient was then tried to be planned with another course of SBRT. And you can see, again, around the orange or pink, that's the dose you want on the tumor. But now you've got a lot of dose out here in the normal structures, some upper cardiac dose, but lung particularly. And that's not as advantageous as you want to be. Next slide, please. And this is with protons. So an area that I think we will be using the proton facility, and you guys at UNC and Duke as well, is retreatment. It does happen, and it's difficult because you've now exceeded what's probably a recommended dose. But if you do that, you really need to be as precise as you can. And this is an example of, as opposed to the other one, which was IMRT planned, this is proton planned. And you can see there's a little, to me, it's a tighter field, fewer beams or fewer need to cover, to interact with normal tissues. So this to me would be a place of protons, and this, in my opinion, will be highly useful when you're doing retreatments on patients who've seen prior radiation. Next slide. That's an example of just when this was a study that looked at dose distribution with 3D IMRT, and you can see that the V20s actually went down with IMRT, which is what you want to see. And this is a little bit light colored. I'm apologizing for that. But if you look at these slides of the V20, that just tells you how much lung is getting 20 gray, which is radiation dose. And what you do want to do is you want to minimize that. And as you can see, some of these doses with 3D were 40%, 27%. But with protons, you're actually able to reduce this. So I think when we first designed a lot of our clinical trials for protons, we failed because we thought we were going to look at efficacy. How much better tumor control do you get when you use protons versus proton radiation? And the issue is photons is just as effective as protons in terms of effect to kill tumor cells. See, we're going to lose that war no matter what you did, because photons can deliver radiation dose just like protons. Very similar. We call it radiation biology effect. I'm not going to, another acronym, RBE, but they're basically equivalent. But where we do have advantages of proton is, if I'm not said it enough now, is with reducing normal tissue effects. That's what we should be focused on. We try to do it, and people have learned that over time. And I'll show you a couple of trials where we're now focusing on, late effects and not efficacy, because efficacy is not really where you should go with these types of studies. Next slide. So here's a randomized trial. One of the cooperative groups, RTOG. Should be a large study. I forget how many patients, but it's in the hundreds. And the randomization is really the photon versus protons, just to see if there's some advantages. These are folks who will be getting chemo prior to radiation, which is a standard of care for stage 2 and stage 3 non-small cell lung cancer. But this study, actually, the focus of it is actually late effects, not efficacy, because that probably was never going to be a successful endpoint to test proton therapy. Next slide. And I like this approach by RTOG. Again, it's a big study, 560 patients, the randomization, as you can see. But then the hypothesis is planned reduction in toxicity will result in increased survival. So the thought is, if you have less normal tissue, you'll have less toxicity, which may translate into survival. I don't really have to have the survival piece. I need to see the toxicity piece. And I think if protons are going to win anywhere, they've lost in a lot of places. They lost in prostate. But if they're going to win any place, they're going to win where they're looking at toxicity and not necessarily efficacy and outcome. Next slide, please. So this is a study that MGH ran and MD Anderson ran. And they actually learned the thing that we probably could have guessed at. Tumor failure rates were no different with protons versus IMRT or 3D. And you really can't expect, if you're given the same dose, you probably would see the same effect. And I think the primary hypothesis here was actually they expected to see some tumor control differences. They did not. So it's a negative study for protons in lung, but they had the wrong endpoint, in my opinion. Now we're starting to look at the right endpoints to see where protons could be useful. Next slide, please. I love this. This is Joe Tepper, who was a chair at UNC for a long, long time. He stepped down, probably 10 years ago, and he's just sort of retired now. He was my mentor at UNC. Really, really super bright human being, very influential in the field of radiation oncology. But when protons first came out, as I mentioned at the beginning of this talk, a lot of folks who invested those millions, if not hundreds of millions, told everybody, well, you should do protons because the treatment fields look better. And I've shown you examples of where the dose clouds look better, tumor coverage might have been a little bit better, and there was less normal tissue in the field. And people wanted to push that, who had spent those dollars, to tell us that, well, you need to use protons because that's gonna be better than photons. Again, I've told you about 2 studies, one in lung, one in prostate, where it wasn't true. And Joel wrote a wonderful editorial. I've referenced it for you. I think it's entertaining as hell. Protons and parachutes. And what he's speaking of is, if you developed a new parachute, and wouldn't you test that parachute? Wouldn't you put it through some studies to see if the parachute was at least as good as the old parachute, if not better? And I love the editorial because it basically speaks of, we don't need to start pushing proton therapy until we do the right studies to make sure it indeed is better and that patients benefit from it. If you get a chance, it's a nice read. I like to tell people all the time, I would put on a parachute that's never been tested with you, and I don't think anybody would. Next slide. I'm getting close to the end, and I think I'm at 12:44, so we'll have a little time for questions. I'm just going to talk a little bit about oligometastatic radiation. And one study we did at Wake Forest, and we had the second study ever published in this area, which we're proud of. MD Anderson beat us out of the gates, but we started to look at oligometastatic radiation because stereotactic radiation, which is an ability to deliver a lot of radiation dose in 3 to 5 treatments. So you're not going 6 weeks, you're not going 5 weeks. Patients come in and get treated over the course of 1 week, but the doses are big doses, and the volumes have to be small. So this would be for a lung nodule, for a liver nodule or liver metastasis, but these things have to be 1 centimeter, 2 centimeter in size. Once you get past 3 centimeters, the volumes are just outside what parameters we know are safe. But for small tumors like lung nodules that are that size, stereotactic body radiation therapy could be a very effective therapy. So where would we use it? So then we developed a study in non-small cell lung cancer where when patients came in with metastatic lung cancer, if you had less than 5 sites of cancer that we could find, and we actually imaged people with MRIs, PET CTs, and CTs. It was required for the study. But if we couldn't find more than 5 sites of disease, your primary cancer in your lung, and either a couple of bone mets or a couple of lung nodules that were in your lungs, we then placed you on our phase 2 study where you received oligometastatic radiation after your chemotherapy. So you were diagnosed, you started your chemotherapy 2 to 4 cycles, and if you still had only 3 to 5 areas that need to be treated, we would do oligometastatic radiation. The beauty of it is it doesn't take 6 weeks to get it done. You can get it done in a week or 2. And I was startled. I have to tell you, I'm old school. I didn't think this would work. I was part of the study. I was actually a big accruer to it, but it turns out it does work, and it's been shown now by several groups, and not only in lung cancer, but in prostate cancer, some other disease sites, where if you can delineate limited disease, however you want to define it, we defined it as 5 or less, then you could actually treat those patients. And if you look at the survival curves, it was randomized phase 2, so there was no phase 3. But the folks who got oligometastatic radiation have tail in 3 years or 5 years, where we didn't see that tail in the patient who didn't receive oligometastatic radiation. And I think it's now become a accepted standard of care for the appropriate patient. I have to keep saying that. Sometimes the medical oncology will send me a patient. It's like that 9 metastases is too many. If you've got 9, you probably got 10. I was the impression if you had 4, you probably had more. But it turns out when you only have 3 to 5, you actually maybe don't have, at least for that point in time, you may only have that for a while. So this was a positive study. And my last comment is really around lutetium-177 with PSMA. This is a therapy that you can use. It's a molecule that attaches to PSMA receptors, so specific for prostate cancer. It's really helped us in terms of understanding not only if you got prostate cancer, but if you're node positive, if you have other disease that we can't see on PET, we can't see on CT. And it turns out if PSMA basically says to you, you have limited disease, maybe a couple of lymph nodes or whatever, we can then direct radiation at those areas that are positive on PSMA. And we're looking now at the studies that have all been done to see if this is the same strategy. If you get limited metastatic disease, oligometastatic radiation might actually be effective in prolonging your survival, or at least I like to tell people cancer is not about curing, it's about making it chronic. And that's my word when I see people say C for cure. I'm like, no, C for chronic. And if we could treat a patient who has 3 or 4 metastasis from lung cancer, but they don't have another metastasis for 3 years, that's okay. We made it a chronic disease. And to me, that's the goal, actually. And I think we're being successful with that. Immunotherapies are doing that for us in a lot of diseases. And so that, to me, is the goal when I think about clinical trials now. Not necessarily curing patients, which we always want to cure patients. We still cure patients, But sometimes making it a chronic disease is a good enough goal as well. Next slide. Okay, I thought I had one more. No, one more. Okay.
Let me check, but I think that was the last one there that we have.
Okay.
And then we go to the poll, and I hope these are working now. Proton beam radiation therapy is not an established treatment strategy for all general cancers versus standard photon beam radiation treatments. So true or false? It's funny because everything was working well right up until we started. Go figure, but I can go ahead and look in on what I've got here behind the scenes, and I should be able to see the answers if you'll please, if you're in the audience, go ahead and designate that as true or false. And bear with us. Looks like Dr. Blackstock, we're running at about 75% true and about 25% false. It's kind of going back and forth. We're shifting back and forth a little bit, but I'd say about three quarters on the true and about 1/4 on the false. How are they doing?
Well, the 3/4 is correct. I'm glad to see that. Maybe, some of this physics stuff didn't, people were still paying attention despite all the heavy physics. But it is not an approved study of therapy for all patients. Proton therapy is still the standard of care in all practices. When patients come to see us, it's selective protons. We do in my practice, kids always go to see the proton folks at St. Jude's because we always feel like that may be an option that could be helpful. There's other indications for me when I see a patient with a difficult retreatment, et cetera. But the majority of patients don't need to see a proton physician or a doctor. Proton therapy for the majority of patients is still the standard of care.
Great. And you'll be happy to know we now have 100% on true. So everyone's self-corrected there. Thank you. Next question. The improvement with the use of proton beam radiation is due to improved dose delivery and normal tissue sparing. And so true or false, again, I can go ahead and monitor that in the Poll Everywhere application and let Dr. Blackstock know the answers to those. So if you'll go ahead and select the one that you feel is correct, true or false, and we'll go ahead and see what answers are coming in. Thanks to everyone who's taking a few seconds here to go ahead and respond to these polls. Again, it's entirely anonymous. Dr. Blackstock, this time so far we're running 100% true. How are they doing on this one?
That was really one of my main points. And I know I probably said it too many times, but it got through. That's the advantages of protons. It will always be an advantage over photons, but it's got to be the right patient, the appropriate patient. But yes, that is absolutely the correct answer.
Great. And then last question you have here. Let me go ahead and advance to this one. Oligometastatic, am I saying that correctly?
You are.
All right. Oligometastatic radiation treatments using Stereotactic Body Radiation Therapy, SBRT, has improved the outcome for patients with advanced non-small cell lung cancer. And this is a true or false. Please go ahead and respond to this one. And again, we will do our best to get you those answers. And looks like so far we're running about 2 to 1 true to false, maybe 3 to 1 now. How are they doing?
Well, I think I should have written that question better because it's really for selected patients. But I do feel like for selected patients, as I described, with limited metastatic disease, however you define it, that there are now studies that have shown that we can improve survival. But it's not for everybody. It's not for every patient. Mm-hmm. So maybe that was a bad question in the sense I should have said select patients with non-small cell lung cancer.
Well, no problem at all. And then the last thing we want to do here is you've got a nice end slide there.
That's your life in the clinical trial world. It always seems like a good idea at the time.
like that. All right. And now we want to give our audience an opportunity to share their questions. It may be, again, that that's not going to populate, but I'll be able to see those questions and relay those to Dr. Blackstock. So if you would like to share your questions, please, I will be on the lookout for those while we're waiting for those questions to come in. So help us understand. We know that from what I learned, that the real focus with the proton therapy is on the pediatric patients. But are there other groups of patients that would strongly benefit from this in select other groups?
There are some other patient populations. They tend to be very small. You know,
Mm-hmm.
if you've got a base of skull tumor or cancer, you probably should see a proton facility or a proton doctor.
Mm-hmm.
Obviously, as I mentioned, for retreatment areas, you always should be at least thought about protons. Pediatrics clearly need to be thought about for protons. So it's kind of a unique clinical situation where you want to think about protons. And I would suggest people send folks for the consult. I just sent somebody up to Hopkins who has protons because they had a recurrent cancer and I just didn't know if I could treat it safely. So that's where I think it's going to be effective. The studies for prostate have been negative. Um, Studies for lung have been negative, as I shared with you, but we're looking at the right way now. We're looking at toxicity, not necessarily efficacy. And we'll learn more. There's a number of studies at a number of different tumor sites that I'm just not familiar with, but we're trying
Mm-hmm.
to test protons, and hopefully we'll learn something about where it's effective and where it's not effective.
Gotcha. Thank you. What do you see? Obviously, the cost is tremendous on this. Do you see this cost coming down, or do you think it's going to be this for the proton therapy, or do you think this is the way it's going to be for several years?
It is not. It's coming down, and I'm sorry, but I'm glad it's coming down. It was way too expensive, and I
Mm-hmm.
said before, which doesn't sound very kind, but I think some folks got into this business for the wrong reason. And now we're seeing CMS and other people say, you know, we're not going to reimburse you at that level. And essentially, you can do an IMRT plan with photons. Again, not another acronym, but you can do IMRT with any old regular photon machine, which is most what everybody else had. You know, 98% of us have photon units. And we've looked at photon IMRT versus proton treatment plans. And you can get there, you get pretty damn close to a proton plan with a well thought out IMRT plan. And the compensation for both is the same now. The problem with the proton folks who got in who are getting out now is they anticipated having that, you know, twice the reimbursement, sometimes 3 times the reimbursement, and that's gone away, which in my opinion, should go away. And the rest of us are in it for the right reason. That's because we want to use it in a way that's most effective, and not for other reasons that are not as, I don't know. Yeah, we're not in it for the
Gotcha.
money.
All right, good to know. Good to know. I have a few other questions, but I'm going to put those on hold because I see that we're getting some questions coming in from our audience. First one, while radiation therapy is considered a local therapy, can you speak to the abscopal effects noted, particularly with some of the newer systemic therapies?
Immunotherapy is it's back on our radar. You know, we talked about abscopal effect for a long time. It tells what abscopal is when you deliver radiation to one area in the body, like a lung nodule, and another lung nodule disappears. And it really is we think it's about immune response. So when you treated that one nodule, the immune system kicked in, and all of a sudden it actually attacked the other nodule. And people have seen that. So I've got to be honest, abscopal effect is hard to believe because you see it once in 100, once in 200, and it's hard to study because it's so infrequent. It is real. I've seen it. Couldn't explain how another tumor disappeared when I treated another tumor, but it's not as often as you think it would be. The immunotherapy folks, because of what they do in terms of stimulating immune system, now I like the idea because we're looking at radiation in conjunction with immunotherapy so that we can see if we can get the abscopal effect. I love that question because that gets a lot of buzz about the abscopal
Mhm.
effect. Doesn't happen as often as you'd like to see it happen, but maybe the immunotherapy folks can help us figure it out.
All right, thank you so much. We've got another one coming in, and unfortunately, the second portion of it was cut off with what we received. So I'll read what we've got, and maybe the member of our audience who submitted that will submit a little bit more. Let's see what we can figure out here. Do you anticipate the ability for the engineers to be able to minimize the size of the machine hardware to create the proton therapy and then it cuts off there. So I don't know if we have enough there to decode the question.
Tim, the answer is yes. If you go to MGH,
Mm-hmm.
which started their unit in the 70s and 80s, probably 80s, Loma Linda, they're huge
Mm-hmm.
units, very expensive units. And I've seen MGH. It's a building with a cyclotron in it. And
Mm-hmm.
now, even though I talked about the size of the one we're looking at Charlotte, yes, these units are much smaller, much more compact, and they're less expensive. So now you can actually do one without having to break the bank. Though $69 million, for us to spend with Atrium is a lot of money. But yes, everything's starting to get down in size, less cost, and that's why we're going to see maybe more people doing protons. But they do it in a way that's more effective and not worried about compensation.
Great, thank you. And one last question. I'll ask this one. What does the team look like to support proton therapy versus other radiation treatments? Because you mentioned this team of physicists, so that's going to be additional staffing that's involved. In terms of when the patient comes in and who's working with the patient, is that comparable, or are there different skill sets, different professionals that are also involved?
I really think it's going to be what you said. The front desk will be the front desk, whether it's protons or
Hmm.
photons. Nursing will be the same because radiation acute side effects are the same with protons versus photons. It really comes down to the maintenance of that unit. Cyclotrons are high maintenance. They go down. Photon units a lot of times are very reliable. The story about protons is you got to anticipate some downtime, and then you got, I've got 11 physicists in my group for 4 LINACs, and anyway, but that many physicists, and I would suspect for one proton unit, we're going to probably have 4 or 5 physicists and 4 or 5 engineers just to keep the thing running all the time like we want it to run. It's a big investment on that end, really. Not so much the front end, the personnel end, but the physics and or engineers are just they're expensive people, right?
Yep. Yep. All right. Well, we are at 1 o'clock, so I do think we should go ahead and wrap up. Dr. Blackstock, this has been amazing. Thank you so much. I want to thank the people of North Carolina for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. I want to thank our team members, Mary King, John Powell, Jason Paylor, Veneranda Obore, Oliver Marth, and Andrew Dodgson. I do want to say a fond farewell. Both Jason Paylor and Mary King are leaving us either at the beginning of the week or next week. We will miss them both tremendously.